Palliative care is a broad concept about approaching patients suffering wherever they are in the course of an illness, and can we manage their experience at the same time as we're treating their underlying disease. Everybody who's a healthcare practitioner does it. Of course, there are specialized services for complex symptom control and complex supportive care issues to help manage suffering along with managing teams. But wouldn't you want your pain managed within a couple of days, no matter when it starts? And if your family is suffering because they can see your illness is progressing, wouldn't you want to have your family experience help with that? I think each one of us would hope that our families would get the help that we would need. So in patients who are able to communicate their situation, it's really important for us as clinicians to understand the underlying causes of the pain, to make sure we understand the pathophysiology, to understand for that patient how it's causing them to suffer. Because pain creates a variety of changes in behaviors. People don't walk around as much, they may not get out of bed, they don't sleep well, they don't eat well, their thinking is completely focused on their pain, and oftentimes they get either grumpy, the grumpy bear syndrome, or they get withdrawn and they just don't talk. So in addition to having a sense of the cause, we need to really do a comprehensive assessment to try to understand the patient's change in behaviors. And each one of those changes, we're trying to normalize that so they go back to being the person they were before. How can we actually then choose medications that are appropriate for the cause to try to improve the patient's life situation? The challenge comes in the patient who's not able to communicate, somebody who's cognitively impaired. So we have tools like the PAINWeek scale, which has been partially validated in Alzheimer's dementia. How can we use that type of scale to be able to, as best possible, assess the patient's experience of the pain, and in each case, whether they're able to communicate or not, can we see changes in behavior as we manage either with medications or with supportive care so that people get back to the life they want to be able to live and we don't see the same suffering. And I think, for the primary provider, the other thing that's important is how long do we spend waiting to get control? How long would you like to enjoy 8 out of 10 pain for? Personally, I think that if, as a primary provider, I'm not well on the path of getting control in 48 hours, I need to think about inviting a pain specialist or a palliative care colleague to join me as a partner to think through what the best strategies are. We should be managing pain quickly, in part because we know unmanaged pain leads to damage in the neurological system and can make the pain worse long term. There's a variety of difficult pain syndromes that occur in patients with advancing illnesses. We can get the complex bone pain, we can get complex abdominal pain, and sort of one of the most challenging is then the neuropathic pain that becomes complex and multifaceted. Again, I would say if I'm not getting good control based on appropriate medication for the underlying causes, within 48 hours, am I getting a partner from pain management or palliative care to join me to think through what are the better options? It is challenging. And, as practitioners, most of us didn't get a lot of training in our medical school or residency training programs. No surprise that we may not understand the complex situations. That's where we, as specialists, are able to help. Every patient lives in the context of family, whether they're related biologically or they've joined together in marriage or they've chosen people to be their friends' family. So those people surround us and can help us. It's really important that we as healthcare professionals hear what those folks experience as a result of the patient's pain. They can often tell us a very important part of the story. Patients don't like to embarrass the doctor. They don't like to complain. They want to put on a brave face. Oftentimes the family members will tell us the real truth. And I think most of us do practice in an office. An office is a very artificial setting. The best place to see what's happening to the patient is in their home. Well, that's where the family is, and the people helping with care. Let's engage them. Let's listen to them. They also are often the people who are helping with the treatment plan to make sure it's working. Let's make sure they not only tell us the story, but they understand what we hope that they will do to assist the patient to get better.